And I'm excited to welcome you to our second live Q&A webinar. Tonight, we're joined by Dr. John Myseros, the Vice Chief of Neurosurgery at Children's National Medical Hospital in Washington, D.C., who is also a member of our Scientific and Medical Advisory Board. Dr. Myseros is an expert in treating pediatric brain disorders, including malformations of the cerebellum, including Dandy Walker. He's graciously agreed to take some time this evening to discuss his work and answer questions about facing a Dandy Walker diagnosis, commonly associated conditions, and various treatment options. But before we hand it off to Dr. Myseros, there are a few things that I want to go over from a logistics standpoint. First, there's a lot of you here and even more of you who aren't here, but will be watching this online later. We received some questions that were sent in ahead of time, and this webinar will last an hour, and we'll try our best to get to all the questions within that time frame, but please understand if we're not able to get to all of them. Second, if you wish to ask a question during the webinar, please type it in the Q&A section at the bottom of your screen, and Chris will read the question to Dr. Myseros, and then you can stay muted unless Chris calls and unmutes you to ask a question verbally. And finally, this webinar is being recorded and will be posted on our YouTube channel at some point early next week. So I think that covers about everything. And without further ado, I'd like to welcome Dr. John Myseros. Dr. Myseros, thank you for being with us today and sharing your work with us. To kick things off, I wanted to ask a couple of questions about, are there other treatment options other than shunts for conditions like hydrocephalus?
So first of all, thank you so much, both of you, for inviting me to do this. It's an honor, it's a privilege to do that. I appreciate the opportunity. Yeah, I mean, so as you've already sort of inferred, the standard gold standard for treatment of hydrocephalus is diversion, is getting the spinal fluid, which is gathering in the brain, out of it there. Initially, for some of you might know that the initial, so I'll use the term CSF, cerebral spinal fluid. It's the water in our brain and our spine. So the original CSF diversionary shunts, diverting the spinal fluid from the head elsewhere, were actually put in the heart. In the early 50s, the original shunts were vascular shunts. So it's not that kids had, or even adults who needed shunts, had heart surgery. It was put in the heart through the facial vein, a little vein in the neck that drains into the jugular vein, which drains into the heart. So, and believe it or not, for as invasive as that might sound, it's actually not that invasive. We do have a number of children who have ventriculoatrial. Atrium is the first chamber in the heart. Ventriculoatrial shunts for a variety of reasons. But I'm sorry to digress. The point being that the initial shunts were put in the heart because we knew that blood flows in this direction, away from the head, through the jugular vein to the heart. We wanted to get spinal fluid from the head out. So any water you put in the vascular system in the heart and the blood vessels will get absorbed. It'll eventually come out through the kidneys. So that's where shunts were placed. The problem with that in a little kid, I mean, technically it's not actually that hard to do, is that in the abdomen, so a ventriculoperitoneal shunt, so the peritoneum is the belly, it's the absorptive surface of the belly. In the heart, you can only make the catheter so long. You can't coil a catheter up in the heart. It'll end up going into the ventricle. You'll have arrhythmias. I mean, it could be fatal. In the abdomen, you can put in as much tubing as you want, with the idea that as the child grows, the tubing will slide out and they have plenty of tubing to become full-grown adults, even really tall adults. So peritoneal shunts started being put in later in the 60s, but the original shunts were put in the heart. So a ventriculoperitoneal shunt isn't the only option with regards to shunts. It can be put in the heart. In really tiny little babies, particularly the babies who are born prematurely, who have all sorts of problems with their abdomen. Sometimes the peritoneum, the inside of the abdomen, doesn't absorb spinal fluid. and they may not have a good vein in their neck to access. So sometimes you're stuck about where to put the shunt. In an older kid, you can actually put it in the chest cavity, because the chest cavity, which holds the lungs, also absorbs fluid very well. Typically in older kids, we might do that. So with shunts, as shunts go, belly, if not belly, heart. If you don't want to put in a shunt, your options are limited by a number of factors. The primary one being the age of the child. So some of the people that are on this webinar may have heard or looked into something called an endoscopic third ventriculostomy, or an ETV. So that is a procedure where you go in into the ventricle, into the fluid space of the brain, and you go into the third ventricle, which connects the two lateral ventricles, right and left ventricle drain into the third, and you poke a hole. You make a hole with one of your instruments so spinal fluid can exit there and try to bypass a block if there's a block. This works particularly well in patients who have brain tumors, who have a block from a brain tumor, and you just open up a hole to bypass the block and the spinal fluid gets out and they can be treated without a shunt. Treating Dandy Walker kids in particular, but little babies who have an open soft spot, an open fontanelle in general, that procedure doesn't tend to work so well, because the fontanelle, the soft spot, is a very easy pop-off valve for these babies. They would much rather inflate their fontanelle to decompress their brain, to relieve the pressure in their brain, than try to push their spinal fluids through some tiny hole that we made. So endoscopic third ventriculostomy. There's another thing that some people, particularly the people in Boston, do, is they cauterize. They go in with a little camera and they burn the choroid plexus. The choroid plexus is the substance in the ventricle that makes spinal fluid. So they sort of try to shut down the factory that makes spinal fluid. And while they're at it, they do an endoscopic third ventriculostomy. Really, the people in Boston are the only ones that have shown great success in doing that. Those two procedures are a lot more dangerous up front than a shunt. If you manage to do it successfully, you might be able to avoid a shunt. But there's something called an endoscopic third ventriculostomy success score. And little babies, particularly little babies who don't have an obvious obstruction, just don't do well from that operation and end up with a shunt. So for instance, at Children's in DC, where I work, there's 5 of us. I have 4 partners. None of us do that procedure in babies because we just don't have that much experience. From what we've seen, it doesn't work very well. And the risk benefit ratio is not in our favor or in the baby's favor. So we typically put in a shunt. To be a little more specific regarding children with Dandy Walker malformation, we can talk about this if some people may have questions. So some people use the term a Dandy Walker cyst. So that's a little bit of a misnomer. So a cyst is a trapped area of fluid. Like cyst is the Greek, I'm Greek. Cyst is a Greek word for bladder, right? So the bladder is just a big balloon of water, urine. So a cyst in the brain is typically a trapped area of spinal fluid. Most kids with true Dandy Walker malformation, so they don't develop a vermis. The vermis is the middle part of the cerebellum. Eric, you mentioned beginning that, you know, I treat kids who have abnormalities in cerebellar, you know, sort of development. Sort of that is sort of the definition of a Dandy Walker variant, malformation, however you want to call them. So some people say, well, this kid's got a Dandy Walker cyst. And what they're implying is that in the back, where the cerebellum is supposed to live, there is a trapped area of spinal fluid, because typically our spinal fluid in our ventricles, the right lateral ventricle, the left lateral ventricle, the third ventricle, the fourth ventricle, the spinal fluid in the spine, they all communicate. If you did a spinal tap and you injected some dye in the spine of a kid and you rolled them upside down and rolled them around and turned them and held them upside down, and you did a CAT scan, you know, sometime later, you should see that dye all the way in the ventricles. All that spinal fluid should communicate. Well, and typically in Dandy Walker malformations, despite the absence of a cerebellum or part of that cerebellum and this what looks like a huge fourth ventricle, a huge spinal fluid space in the back of the brain, that does typically communicate with the ventricles. And the reason we know that is we used to, even I used to back in the day, if a baby was born with hydrocephalus, too much water in the ventricles, and a big spinal fluid collection in the back of the head, we would put in a little needle and shoot in some dye and roll that kid around and put them in the CAT scanner. And if the dye didn't show up in the fourth ventricle, we knew that the fourth ventricle, the back of the brain, was trapped. And we would call that, quote unquote, a cyst. But in most babies, the dye does go into the fourth ventricle. And the reason that's an important distinction to make is no matter how big the spinal fluid space where the cerebellum was supposed to be is, a shunt from above, one shunt should take care of everything. It's very rare that it doesn't. So if you have a fourth ventricular CSF collection cyst that doesn't communicate with the ventricles, sometimes those kid needs 2 shunts or other procedures. So you asked me, are there any other procedures? In a little baby, if you have an endoscope, if you have a camera, you can, and I have gone through the ventricle and poked the hole into the fourth ventricle so that the two do communicate so that you can use one shunt. Otherwise, you might need a shunt in the front, a shunt in the back. In an older kid, and I think, Eric, you'll know what I'm referring to, you know, there's people who are trying to figure out ways to take care of Dandy Walker cysts using teeny little robots and all sorts of things. So in an older kid, it's possible you can open up the back of the head. I don't mean to be crass, everyone who's listening, but this is what we do, right? So you can make an incision, remove a piece of bone, open the covering of the brain, and put a big old hole in the cyst. So it's not trapped anymore. So the spinal fluid can flow down the spine and the cyst collapses, and now all the spinal fluid spaces communicate. I have to tell you, in 31 years, I've never done that. I haven't needed to do that. I can't tell you how many kids with Dandy Walker or Dandy Walker variant I've shunted. I've seen a lot of kids with Dandy Walker variants who haven't needed a shunt. There's sort of, and there's, as you all know, Eric knows as well as anyone probably in the planet, there's a variability, right? There's a gradation. Some kids have a little bit of the vermis missing. Some kids have all of their vermis missing. Some kids have a vermis but are missing some of their cerebellar hemispheres. So, and that may or may not be related to, maybe associated with hydrocephalus. Usually the kids who have a true Dandy Walker, like no vermis, they have hydrocephalus. Most of them do. And a lot of kids with Dandy Walker variant also have hydrocephalus, but there's a fair amount that don't. There's some kids who hit their head and get a scan and just incidentally, oh, by the way, you have, you know, a Dandy Walker variant. It's probably on the minor side. Maybe they're missing a little bit of their cerebellum. Nobody's ever picked up any, you know, neurocognitive or motor delays. Most kids, you know, most kids with Dandy Walker malformation who have delays, they're typically, I mean, they can have intellectual disabilities, but they typically have like motor delays and coordination delays. And that all makes sense because that's what the cerebellum does. It has a lot to do with our sort of coordination, spatial recognition function. It doesn't have to do with strength in particular, like power, but it has to do with coordinating our power. So there are other procedures you can do for that was a bit of a long-winded answer, but there are other things you can do for hydrocephalus. But for the purposes of our discussion, CSF diversionary shunt.
When families come to see you in clinic, either when baby is still in utero or after birth, and they find out that their child has Dandy Walker, what are questions, what are some of the things that they should know, or questions that families should ask, or are there things that they should be prepared for, especially a new parent who's never perhaps heard of Dandy Walker malformation?
Well, you know, it's and Eric, I'm not going to delve into your own personal experiences and life, but you know the answer to all these things, right? So that's a difficult question. You know, some people come nowadays with the internet and access to, you know, sort of an inordinate amount of information, most of which is probably fairly accurate, some of which is not. You know, I would caution anybody that's looking on the internet for any medical information and or advice, if you read 5 or 6 things that all sound similar, and then you read something that sounds completely different, it probably is different. You probably shouldn't listen to it. But, if I were a parent and, my significant other had a fetal ultrasound and they said, hey, listen, your kid may have a Dandy Walker malformation. The questions I would ask, of course, I'm a neurosurgeon, so it's easy for me to think of these things, but that's what you're asking me, right? Number one, is my baby going to be normal? Well, I don't know. I don't know the answer to that question. I can tell you that just logically speaking, after the baby's born and gets an ultimate definitive MRI, which is the best test to do, you can make a prognosis a little better. But even so, I mean, we see devastating appearing MRIs and the kids turn out to be great. We see MRIs that look practically normal and the kids have all sorts of problems. So the two don't necessarily correlate. But the questions I would ask is my baby going to be normal? If not, what kind of problems could I expect? If I've done a little bit of reading, okay, you say he or she has a Dandy Walker malformation or a Dandy Walker variant. Do they have hydrocephalus? Are they going to need an operation when they're born? If they don't have hydrocephalus now, most ultrasounds, prenatal ultrasounds are done like 20 weeks. If it's not there at 20 weeks, might it be there at 38 weeks when the baby's delivered? Should the baby be delivered early? If there's hydrocephalus, do we need to get the kid out of there so can they get a shunt earlier? And then down the shunt road, there's a billion questions. What's it look like? How do you put it in? What are the risks? How long is the recovery? How often do we have to see you afterwards? Is this shunt going to last forever? If not, how long is it going to last? What's your experience with longevity? The question that you asked, are there any other surgical options? I did mention, and I don't want to digress again, but that ETVs work much better in older kids than in kids who have open fontanelle. So it could be that a baby ends up with a shunt, and then depending on their anatomy and how things look when they're older, they have a shunt malfunction, and maybe at that point they're a candidate for an endoscopic third ventriculostomy. Again, that typically wouldn't be the Dandy Walker kid, but it's possible if they ended up getting a scan and their ventricles are big and they're sick, but the fourth ventricle is tiny and all the other ventricles are big, then maybe popping a little hole in the bottom of the third ventricle bypasses the system and you can get away without a shunt. But to do an ETV for most people, that's a very we need special equipment, special people, a team, first thing in the morning, get an MRI, take a look, be thoughtful about this. Many kids who present with shunt malfunction don't really have time for all of this workup. They come in, they're sick, they need a shunt revision, you revise your shunt. But if there were a child who wasn't particularly sick, clearly had a malfunction, you had time to figure it out, you could potentially do an ETV at that time. So those are the questions as a parent that I would ask. Of course, I would probably end up, if I was seeing the neurosurgeon, asking him or her 1,000 other questions that didn't apply to him or her. What other problems might they have? I mean, generally speaking, kids with Dandy Walker malformation can have other, they can have heart problems. They can have, they can have an extra digit or have their fingers fused. It's called syndactyly. They can have facial issues. They can have kidney issues. Most of those things are pretty rare. Typically, the thing that they have is hydrocephalus, if they have that, and not all of them do.
I want to ask, but I want to open it up to the Q&A here that Chris is going to moderate for us. So if folks can start typing in their questions, and then Chris will tee those up.
Mm-hmm. Yeah, as Eric said, there's a question and answer function that you should see at the bottom of your screen. So if you have questions that you want to ask Dr. Myseros, go ahead and type those in. I'll, in the meantime, start out with a couple that were submitted ahead of time. And actually, Dr. Myseros, you touched on a couple of these just a minute ago, but what does the lifespan look like for someone with Dandy Walker? Like when you're getting that diagnosis either in utero or right after birth, what should a parent expect?
Well, I don't, because I'm a pediatric neurosurgeon, I don't follow these kids past into adulthood. I don't know what the statistics are. I should say that generally speaking, kids with Dandy Walker malformation do pretty well. Just being shunt dependent. So let me explain that term for a moment. In most people, babies included, if you place a shunt, if you put in a tube to drain spinal fluid out of the brain to decrease the pressure, the brain is going to like that. And the developing brain in particular is going to like that. And that's why we do it, right? The purpose of a shunt isn't necessarily to make the ventricle small. The purpose of the shunt is to equilibrate the pressure in the head. You want it to be normal. You want the brain to not to be free of pressure so it can develop the best that it can. In most kids, that ends up being pretty small ventricles, because most of us that don't have hydrocephalus have pretty small ventricles. So by definition, if you have a shunt, your life expectancy will be shorter than if you didn't. Because if you take all comers with shunts, I mean, there are kids who are going to have shunt malfunctions, and they're probably going to have kids who are so shunt dependent that they have a shunt malfunction, they don't get treated quickly enough, and they'll lose their life. That can't happen. In this day and age, in a place like the United States, that would be very uncommon, but not everybody has immediate medical attention, unfortunately, even in this country. You could live in a remote place in this country, and you could live, in Anchorage. Well, Anchorage, not so much, but like in Nome, you could live, many hours away from acute neurosurgical care. And in a kid who's so shunt dependent and a shunt malfunction puts them in a coma almost instantaneously, you may not make it. So a shunt, just having a shunt and being shunt dependent will by definition decrease your lifespan. That doesn't mean that you can't have, you can't live for 90 years, but you need to have really good care. Mm-hmm. That goes without saying.
Yeah. Thank you. I think that's a great answer and very, very informative. Kind of going off of that, what are some signs that parents and individuals with Dandy Walker should be aware of when there is a shunt failure? What should they be looking for as signs that they need to seek that urgent care?
So, we have this, most particularly pediatric neurosurgeons, so adult neurosurgeons can take care of shunts as well. I mean, when we train in neurosurgery, we all learn how to put in shunts and take care of shunts. But because hydrocephalus tends to be a pediatric problem, pediatric neurosurgeons have a little more experience. There are adult neurosurgeons who take care of a lot of patients with adult onset hydrocephalus, like normal pressure hydrocephalus, who have a huge experience with shunts. So when I transition my pediatric patients to adult neurosurgeons, I make sure that they're followed by somebody who's actually experienced with shunts. Anybody should be able to take care of it, but there are nuances to shunts. Let me digress just a little bit. In big medical institutions, particularly academic institutions like big university hospitals, there's most of you probably know that are listening to this know what residents are and fellows are and attendings are and fellowships and residencies and training levels and stuff like that. So in a lot of places, the shunt is sort of the quick and easy operation, and you send the junior most resident to put it in. So that is, in my opinion, just a setup for catastrophe. Because although technically speaking, yeah, it's not like taking out a brain tumor or clipping an aneurysm or doing a cervical disc or something like that. There are so many places where something can go wrong, or very subtle little things that make the operation quick, efficient, and safe, that if you screw it up and end up with once you've had one shunt infection, your chances for shunt malfunction and shunt infections for the rest of your life goes up significantly. So you want to avoid that first infection. So don't send the junior resident to put in the shunt. If the shunt's misplaced a little bit, if the incision isn't closed very well, if the shunt is exposed, all these little things make a big deal. When the first shunts were put in, they were actually put in Philadelphia, and back in the day, it was called, I think, Cleveland City Hospitals. It's now Case Western. Frank Nelson in the 50s was putting in shunts. He was the professor. He was a 70-year-old guy. He'd send his residents out to do the brain tumors. He would do the shunt. He wouldn't let anybody touch a shunt, only him, for this exact reason that I'm mentioning. So I forgot what the actual question was, Chris.
Um,
Oh, the shunt signs of a shunt malfunction.
symptoms or warning signs of a shunt.
Yeah, so it depends on the child, and it depends on the age. A shunt malfunction in a baby who hasn't had a shunt very long, the kid can get irritable and start vomiting, but the first thing they'll do is their fontanelle will get really full. It's like easy to tell, because a functioning shunt, the fontanelle will just sink in. When the pressure in the head is lower than the atmospheric pressure, the pressure around us, it'll sink the soft spot in. So if the soft spot, if the fontanelle bulges back out and the kid's vomiting and just looks, punky and is irritable, particularly if they start to cross their eyes, or in real severe circumstances in really young babies, their eyes they'll actually look down. It's like they're looking at the floor. The only way they can look at you is to tilt their head back. It's called a forced downward gaze. That's the sign that a baby has increased intracranial pressure. They have hydrocephalus, and if they have a shunt, then they're showing symptoms that they have hydrocephalus again because their shunt's not working. In the older child, lethargy, irritability, progressive headache, unexplained vomiting, crossing of the eyes. Not necessarily in that order. There are some kids who have shunt malfunctions who can percolate along for a long time. I recently operated on a little girl. She's not a little girl, she's like 16 years old, who I hadn't initially operated on her. She was operated on in another state, but she had spina bifida. So she was born with her spinal cord open in the back. So about 65, 70% of those kids in our experience end up with shunts for hydrocephalus associated with spina bifida. So she wore eyeglasses, and she lost her eyeglasses. And she really didn't notice how slowly her vision was deteriorating. She had no headache, no vomiting, no other symptoms that children with spina bifida in particular have. Like they can start having leg weakness and scoliosis and other things associated with their spina bifida driven by a shunt malfunction. She had no other symptoms until she showed up in the emergency room because she couldn't see and she was almost completely blind. Without headache, without all the warning signs that we tell parents every time we meet them and we beat into their heads, these are the things to look out for. This girl had none of those. All she had was chronic progressive visual loss. So every kid is a little bit different, but commonly the most common thing, headache, unexplained vomiting, emergency room, image, shunt revision.
Thank you. And we just got a question from the chat that kind of piggybacks off of that. Someone says, they had a shunt placed almost immediately after birth and then a revision a few weeks later. No issues since. Is there kind of a standard timeline on how long after that they can expect the shunt to work, or is it really variable?
So there's varying statistics depending on what you want to believe, but I can tell you that generally speaking in the literature, it is extremely rare to make it to 10 years of age if you've been shunted as an infant without at least one shunt malfunction. It's almost impossible. Like the malfunction rate is about 99%. We do have kids. I have kids who are 18 who've never had a shunt malfunction, and we can talk about that in a moment. I'm convinced that some of those kids actually, their shunts don't work, but we'll talk about that in a moment. So typically by age 10, you've had a shunt malfunction. The malfunction rate, I think in the literature now for all comers in the first year of the shunt's life is about 50%. My malfunction rate in the first year of life is probably around 15 to 20%. So why is that? Is that because I'm such a great surgeon? No, I don't think so. There's a lot of great surgeons who have all sorts of problems. I can tell you that although I have residents and PAs and fellows, I'm there for every shunt and I do the major portion of the procedure, and I'm fastidious and OCD like most neurosurgeons are. So I do it the exact same way every single time. I'm very quick. I don't expose a shunt. I don't have any, my infection rate, we'll talk about that in a moment, is exceedingly low. And as I mentioned before, if you can avoid that first shunt infection, you're giving that kid the best shot. Not all shunt infections, I'll just mention. So the shunt infection rate in the United States, depending on what year, is between 9 and 12%. So 1 out of 10 shunts is going to get infected. And if it gets infected, for the most part, you can't treat a shunt with antibiotics. You have to remove the hardware. You have to remove all this foreign body that you put in this baby. You have to drain the spinal fluid outside the head with a catheter, so you can test the spinal fluid and make sure that it's clean before you put the shunt back in. So in, my shunt infection rate, I don't want to jinx myself, is, less than 0.5%. It's very low. It's not zero. I've had shunt infections, but, I've been at Children's in Washington for about 19 years. I've probably had maybe 3 or 4 infections, and one of them was bacterial. That's what you're worried about. We've had kids who've had blood infections, and then from the blood infection infected their shunt. Or I've had, a urinary tract infection and a bad kidney infection in a spina bifida kid, and then end up infecting their shunt. So that's not a post-surgical shunt infection, but they do get shunt infections. So shunt infection rate, generally speaking, is about, it's about, I would say standard is about 10%, but anywhere between 9 and 14%. It should be, in my opinion, it should be less than 2%. That shouldn't be a huge, when you send a family home, they should look out for it, but they shouldn't be, watching the incision and checking the kid's temperature every 3 seconds to make sure they don't have an infection. It should be very rare.
You mentioned a little while ago, instances where you wonder if the shunt's not even working at all. Is it common for a shunt to stop working without some of those telltale signs that you mentioned earlier?
It is exceedingly uncommon. So the reason I say that, if I see an 18-year-old with a shunt placed 18 years earlier and they've never had a shunt malfunction, statistically speaking, if 95+% of kids have had a shunt malfunction in the first 10 years of age, how did this kid make it to 18 without a shunt malfunction? Either they're super, super lucky. The shunt, you get a shunt series for everybody. A shunt series is a plain x-ray of the skull, the chest, and the abdomen to see the shunt, actually see the tubing and make sure there's no areas where it's broken or disconnected. So if you see an 18-year-old who gets a scan and their ventricles are small, just like they were 5 years ago and 10 years ago, and you get a shunt series and the shunt series shows that the shunt's in one piece, it's not broken, it's not pulled apart, and the kid looks well, the assumption is shunt's in one piece, ventricles are small, shunt works, leave the kid alone. But you don't know that for sure. You don't know that it's working for 100% in any kid. You assume that it's working. The only way you know 100% is to pull the catheter out of their belly and hook it up to a bag and see if anything comes out of it. And if over a day or two, not one drop of spinal fluid comes out, shunt doesn't work. Haul it out, see you later. One of the reasons I say this is because I have, over the years, I've had a couple of probably over 20 kids who have presented to me with shunt-dependent hydrocephalus and shunt disconnections or breaks. They get a shunt series and you can see their shunt, and like right here or right here or right here, the shunt disconnects, and you look at the rest of it and it's all coiled up in their belly. It's sort of migrated underneath their skin and it's just a big coil sitting down in their pelvis. And there's a gap this far. You can't see my finger, it's down on my belly, but there's a 2-foot gap between the two ends of the shunt. Well, that shunt's not working. No way, no how. How can that be? Kid's not in the ER, they're not puking, they're not crossing their eyes, they're not screaming with headaches, they're not in a coma. How is that possible? So if I see a kid like that, and I've seen kids I saw a kid who wrecked on his skateboard, and he broke his collarbone. And they got an x-ray of the collarbone, and they noticed up higher, like behind the ear, a tube. And they said, hey, what's that tube behind your ear? And the mom said, that's, Joey's shunt. Well, when they did the x-ray of this clavicle of the collarbone, they didn't see a shunt. They just saw a tube up here. And they went and got a belly x-ray, and there's the rest of the shunt. So that kid ended up getting an x-ray because he had a broken clavicle and found out that his shunt's disconnected. So they get sent to me. Oh my God, the shunt's disconnected. What are we going to do? I get a CAT scan or an MRI. I compare it to old scans. If the ventricle's a little bit bigger, I go and I send them to an ophthalmologist. An ophthalmologist can dilate the eye, dilate the pupil, and look at the optic nerve. Increased pressure in the brain will transmit across the optic nerve. An ophthalmologist can see it. It's called papilledema. So I send the kid for an eye exam, no papilledema. Parents say, well, what do we do now? So, come back in 6 months. We'll repeat the x-ray. Repeat the CAT scan, repeat the eye exam. Ventricles are the same. Eye exam still looks fine. Kid still looks fine. Maybe kick the can down the road another 6 months or a year, still the same. My suggestion, take the catheter out of the abdomen so you don't have a catheter just floating around there for the rest of your life, looking to do something bad. It's clearly not helping your brain. Take out the catheter, leave the rest of the shunt, see you back in a couple of years. No more neurosurgery for you. Maybe 25 kids, 30 kids like that over the years.
When families travel, let's say they have a kid with Dandy Walker and hydrocephalus, they're shunted. Are there certain precautions that they should take? Should they take images with them when they travel, or what happens if they're on the road and they get the individual gets into trouble? What should they do?
I would still suggest, and it used to be that I'd say, you should always have a CD or a USB flash drive of the latest picture of the brain, CAT scan, MRI, fast MRI, whatever it is that you're doing, that shows what the ventricles look like when the kid is well. So that, God forbid, if they end up in somebody's emergency department and they get scanned, the people there have something to compare to. We see kids all the time from outside institutions who come in for an evaluation because their parent think they may have a shunt malfunction, and we have no images to compare to. We have no way to judge whether these ventricles are bigger or smaller. Is this really the shunt? Is it something else that's generating the symptoms? Nowadays, there's a lot of, online access. There's, people have Google Dropboxes and WeTransfer, and at our institution, there's something called Ambra Health at our institution. Many hospitals around the country use something called Ambra Health. It's sort of a sort of username and password accessed depository of images where you can load images. Or one hospital, say you end up, you're in Texas and you end up in Houston and you're at Texas Children's Hospital. Texas Children's Hospital can contact Children's National and say, hey, can you share these last images with us? But in the event that that's not the case, or you're in, Nepal or something like that, you should have a copy of the most recent imaging studies when the child was well.
Thank you. I think that's fantastic advice for a lot of families who might be traveling or away from their current or preferred hospital under any circumstance. We had another question come in on the chat. Someone describing a situation where their tubing was disconnected from the shunt, so new tubing was placed, kind of like what you were describing earlier, but the old tubing was left in the abdomen. Could this cause any problems going forward, having that just floating around down there?
So excellent question. Leaving the tubing in the abdomen is not wrong. Let me just start by saying that. It's very rare, and I don't mean to make light of this. This may apply to somebody who's watching or listening to their child, but peritoneal catheters are pretty easy to put in, but they can do all sorts of kooky things. The catheter, if you've ever seen or felt a shunt catheter, it's silastic. It's fairly soft, but it has some turgor to it. It has some firmness to it. And all of the organs in the belly are not that firm. We've seen kids, particularly, I've seen it maybe 2 or 3 times over the years, come in the emergency room with a little white tube coming out of their butt because the shunt has perforated their colon and migrated through the rectum and come right out of their anus. Now, you'd think that if that happened, how could that kid not be sick, right? How can the colon is like the dirtiest place on the planet? How could a shunt, which is pristine, sterile, right? The brain and our spinal fluid and our spinal cord are the mother of all waters and circulations and sterility. They need to be perfectly sterile. How can a shunt draining spinal fluid from the brain work its way into the colon and not end up with stool spilling into the belly and causing a belly infection, or an infection climbing all the way up to the brain? It does happen. Like the kid may show up with only that. Hey, look at my baby. He's got a white tube coming out of his butt. Well, that's the shunt. So shunts can do, and people have had them. I haven't seen it, but I've heard of same thing, white tube coming out of the mouth because the shunt perforated the stomach, migrated up the esophagus, and poked out of the back of the throat, causing gagging and choking and stuff like that. So if there's a tubing in the belly that's not doing anything, my opinion, not everybody's opinion, take it out. Don't let it sit in there. A functioning shunt is doing something. It's very important and you should leave it alone. But when I see a shunt disconnection and I prove over a long period of time that the shunt's not working, I send them, to a general surgeon. They put a scope in the belly button and they fish it out. It's like fishing line. Pull it out, and then you don't have to worry about that. Well, I call them dead catheters or orphan catheters. Catheters are just sitting around doing nothing.
The field of neurosurgery, are there improvements that you would like to see whomever manufactures shunt devices make, or things like that? I come at the question from the perspective of, let's say, you have a kid that they've gone through their first shunt revision, so now they're post 10 years old. At what point could they expect to need another revision? And are there things that those that make these shunts, whoever those are, they should be doing or looking at to improve that technology?
So we don't, I wish we could predict when a shunt might malfunction, but we can't. The only, and this is controversial, like some of my partners, one in particular would not agree with me on this issue, but all of the catheters that I put in now, and I have been probably for 20 years, have antibiotics impregnated into the silastic of the catheter. Like when you look at the catheters, they're orange in color because they have antibiotics, and that's the color of the antibiotic. And when they go into the body, they start to release the antibiotic slowly, so that if there is some bacteria that's been tracked in there during surgery, it's possible that that'll get squashed and you will end up with not having a shunt infection where you may have had before. So I do think that antibiotic impregnated catheters are an advancement in the longevity of the shunts, primarily by decreasing the infection rate. But there's lots and lots of different kinds of valves. You've got people who are listening, you probably know there's a billion on the market, and nobody's ever shown that one is any better than the other. There's shunts that you can program, you can turn them up and turn them down. There's shunts that have a siphon control, so when you stand up, the spinal fluid doesn't flow too fast out of the head and cause low pressure headaches. Nobody's ever shown, and lots of papers have been written about various shunts, shunt devices, siphon controls, programmable shunts, put them in the front, put them in the back. Also, there is no real difference. The one thing that I do think that, and this is my personal opinion, I do have a medical student working on this to just look at my numbers. When I put in the ventricular catheter, when there's a shunt malfunction, usually it's because the catheter in the ventricle blocks. It's seldom the valve or the catheter in the belly. It's a catheter in the brain. So I use a little endoscope. It's called the NeuroPen. It's a teeny tiny little camera that goes inside the shunt catheter. So when I put the catheter in the ventricle, I make a little hole in the end of the catheter and I pop out the end of it with this little camera, and I can see it up on a screen, and I can make sure I'm in the ventricle. and I can park the catheter wherever I want to try to keep it from getting blocked, to optimize the position of it. Again, never been shown in large series to make a difference in shunt malfunction rates. I'm convinced it does. I would never put in a shunt without it. It takes me an extra minute to do it, and I know exactly where the shunt is. Because otherwise, you put in the catheter, you see spinal fluid come out, the assumption is it's well placed, you hook it up, and you're done. Probably 90% of surgeons do that. Probably more than that, maybe 95%. But a few of us won't do that. We put in the catheter and we put in a little camera so we know where it is, and then we hook it up to the shunt. So I think that advancement has helped. It certainly has helped me. I've been doing that, probably for about 24, 25 years. I learned it I used to practice at Cincinnati Children's, and I learned it from my partner at that time, Kerry Crone, who's sort of the master of neuroendoscopy. And it's a wonderful tool. It's a teeny little camera. They're throwaway cameras, and I can see the inside of the ventricle and know where I am, and I know where I've put the catheter.
I think we have time for a couple more questions. I've got another one here, and this is maybe a little more general and kind of going back to what we were talking about initially, but do you see like a development plateau in children with Dandy Walker? Is it possible for them to develop normally and achieve all their learning goals? Does it really vary in your experiences from what you've seen as a lot of these kids grow up and mature?
Yeah. It very well. So those are two different questions. Is there a development plateau? And do these kids develop normally? So I mentioned previously, I mean, there's a huge spectrum of developmental progress in these children, right? Some of them are neurologically devastated. And there's kids with Dandy Walker malformation who are wheelchair bound and require 24-hour care. Not a lot of them, but there are. Particularly if they're associated with other, you see higher incidence of Dandy Walker in kids with trisomy 18 and 21 and, various other genetic disorders. But there are kids with shunted hydrocephalus and Dandy Walker malformation who are neurocognitively, intellectually normal, even precocious, even above normal. And everywhere in between. The spectrum is literally that big. And just because a kid starts off with developmental delays, it doesn't mean they're going to end up, they may be a little slower to get there, whether it's their motor development or their, cognitive and intellectual development. But just like anybody else can continue to learn and progress and grow, a kid with Dandy Walker malformation can too, throughout their teen years. All of us, there is, I don't know the data right now, but there is a bit of a plateau for all of us. I'm 59, and like statistically speaking, I'm probably dwindling. I don't feel like I am, but our sort of brain maturation is peaked by 18, 19. That's when we're done myelinating all of our axons and our brain is done developing. But I think we can learn and develop well beyond, and that would include children with disabilities or children with hydrocephalus, Dandy Walker malformation, congenital hydrocephalus, spina bifida. All of these kids can continue to learn and progress, into their adult years for sure.
Things we frequently hear when families get the diagnosis of Dandy Walker, especially in utero, is that they're given a grim prognosis. Not from the neurosurgeons, but many times from radiologists. What advice, would you give to families that come into your clinic and your office and they're scared, right? They've been told that this kid could be devastated, and they're literally making decisions whether or not to continue that pregnancy. What would you share with somebody in that situation?
So unfortunately, I can't tell them, like, I can't predict for them what will happen. I can tell them there isn't chance that your kid is going to be, there's a very small chance that your kid's going to be devastated, that you're going to have to care for this child their entire life. They're not going to go to college. They're not going to work. They're going to be dependent on your care forever. They won't likely speak or walk, on and on. Small chance. Depending on what that prenatal image looks like, I might be able to predict that the child will need a shunt. And if they already have hydrocephalus prenatally, they're going to probably need a shunt. So by definition, those kids will have a higher chance of intellectual impairment. And because they have a shunt, have further problems in life, shunt malfunctions, potentially, devastating neurologic sequelae from a shunt malfunction. It's also possible that even with a shunt, they live a normal life and are, highly functional kids who can live independently and have, productive lives where they're happy, whether they end up with a, partner or not. Those things are all way down the road. We don't know. And then there's some kids who will be perfectly, at least to anybody who can tell otherwise, perfectly normal. And probably the perfectly normal kids are not a lot of them. And the completely devastated kids are not a lot of them. And they're like everything else in life, there's a bit of a bell curve and you'll fall somewhere in between. It's a bit difficult, unless there is just some catastrophic finding on the MRI. I would never and this is a bit of a personal thing as a neurosurgeon, as a parent. I would never urge somebody, hey, you know what? I don't think you're going to be able to handle this. You should probably consider, not carrying this baby to term. I have a daughter with Down syndrome, right? So I didn't know, incidentally, she's just turned 26, right? And she's an awesome kid. But, I didn't know, we didn't know before she was born that she had Down syndrome. If we had, would we have changed what we did? Knowing me and her mom at the time, no, that's just not the way that we think. But, people do, for kids with Down syndrome or hydrocephalus or Dandy Walker, people do make decisions not to carry through the pregnancy. That's a very personal decision. But with rare exception, I would never sort of insinuate that somebody go down that road. Yeah, because all these kids, my daughter included, they're kids like any other kid. They're different. They may take a different path, but they're still kids and they grow up to be adults and they're still wonderful and you're still going to worry about them. And usually their siblings are going to still treat them like their siblings, regardless of what their problem may be. They'll still tease them and beat them up and get into fights with them and stuff like that. And then that's the way it should be. So I'm not, again, if I really thought that an MRI or a prenatal ultrasound looked just absolutely horrendous and devastating, I would tell the parent that. I'd tell them, I wouldn't tell them what to do about it, but I'd tell them that. I said, listen, this does not look good. But unless I knew that with a fair amount of certainty, I'd say, if it were me, you wanted a baby, have the baby and take care of him.
Let me ad-lib this one a bit. We had one other question come in. And the question is around knowing that the brain basically adapts to having the shunt once it's placed. However, if a child is over-shunted as a small baby and develops craniosynostosis, and eventually they would have to have surgery for the stenosis, would they still have to have a shunt, or would the brain adjust to extra space available for the fluid created by the surgery? And is that related to slit ventricle syndrome or something like that?
So that is boy, you guys are smart. Most neurosurgeons don't understand this, to be honest with you. So first of all, craniosynostosis is premature closure of the skull. So that typically craniosynostosis is congenital. You're either born with it or you're not. And what we typically see is a single suture synostosis. Sagittal suture, these kids have these long, narrow heads, or the metopic suture here, they have a forehead that looks like a triangle. And we typically nowadays, we cut out the suture and put them in a molding helmet, and it rounds out the head, and the brain has room and stuff like that. The rare exception is an acquired craniosynostosis. So a kid who's been shunted so well that their sutures come together, they get really sticky, and then they close before they should. And the way that you know that isn't necessarily by the shape of their head. The way you know that is because their head circumference really slows down or even stops growing. And their brain has not stopped growing. So what happens? It grows, and typically as it grows, the ventricle gets smaller and smaller because it's trying to get room. So it's pushing more and more spinal fluid out of the brain through the shunt. And eventually the ventricles get so small that they occlude the catheter and you have a shunt malfunction. Sometimes the ventricles, when the shunt stops working, will not get big, because typically in a shunt malfunction, shunt works, small ventricles. Shunt doesn't work, big ventricles. That's why you need an old scan to compare to. You get a kid with a shunt malfunction, ventricles are big, you have a shunt malfunction, let's go fix it. The problem for us is when we see a kid with small ventricles, they look just like they do when the kid is well, but the kid has every sign of a shunt malfunction. They probably have, people use the term slip ventricle syndrome. Eric, you brought that up. I don't use that term. I think these kids have craniocerebral disproportion. I think their brain is too big for their skull. Their sutures have shut down. They essentially have an acquired craniosynostosis, and their ventricle has no compliance. Compliance is the term we use for stretchability. Most kids have compliant ventricles. Shunt stops working, they blow up their ventricles. But in these kids who have craniosynostosis, sometimes, even if you get a CAT scan, it's not clear that the sutures are closed. Usually you can see them. But their presentation is shunt malfunction, small ventricle, fix the shunt, kid feels better, goes home, comes back in very short order with another shunt malfunction. It's proximal again in the head. You change the catheter, they feel better, you send them home, they come back again. This kid who has repetitive proximal shunt malfunctions probably needs, as your caller already said, a bigger head. So their skull shut down, it's not growing, give them more room. So you give them more room. We have lots of CAT scans of kids that we've done this to. It's not a lot of children this happens to. And you get a CAT scan after surgery, and the skull is out here and the brain is here. You've given them so much room. You re-image that kid in a few months, the brain is completely expanded, filled in the space, is so much happier. You know, they had a 40-inch waist and they were wearing 30-inch pants, and you gave them 45-inch pants. And now their brain is happy. Their ventricles in response will get bigger. And hopefully their repetitive shunt malfunctions stop. But to cut to the chase, they still need their shunt. They still have hydrocephalus. You've just now given them more room. You've given their ventricles some compliance, some stretchability, so that they don't keep occluding their proximal catheter and having repetitive shunt malfunctions. That's a very difficult diagnosis to make and decision to make. It's one thing to have a shunt malfunction. It's an entirely different thing to have some surgeon tell you, listen, we need to take your kid's skull apart and make it bigger. It's a big deal. We do it, and actually it's just miraculous. It helps so many kids, but it's just not very common that it happens. Great question. Superb question.
Thank you.
Joining us tonight and doing this. And thank you for being with the Dandy Walker Alliance from the beginning. Going back to 2006, I remember your encouragement and support, and that really led to the formation of the Dandy Walker Alliance. And we are so grateful, many of us, to have our loved ones being treated with your skilled hands, and we think the world of you and are so appreciative for all that you've done for us. And we want to thank the families for joining us tonight. And means the world to us, Dr. Myseros. It really does.
You're very kind and gracious, and it's been my honor and my privilege. And if I can ever help anybody, just let me know. Thank you so much.
Thank you.
All right.
And thank you all for tuning in tonight.
Thank you all.
Mhm.
Bye.
Take care.
Bye-bye.